The coronavirus pandemic has infected over 100,000 individuals and has led to the death of more than 1,000 people in Nigeria. The second wave of the virus has proven to be more deadly and spreading more rapidly than before. Now, the new strains identified in several countries and imported tonight to other countries, including Nigeria, remains a major concern, with health authorities insisting that abiding by safety protocols is the sure way of curbing community transmission. That's part of what we'll be talking about right now. So joining me in the studio is the CEO, Health Emergency Initiative, Pascal Achinene. Pascal, good morning.
Good morning.
It's great to see you this morning.
My pleasure. Well, let's happy Valentine.
Yeah, exactly. You know, it was a very cool Valentine. Yes. Everyone just staying at home. The point there is indoors, exactly. Because the point there is you want to go out and then you think you remember coronavirus and then you have to stay home. All right, now the issue of community transmission, a lot of people still don't understand when you talk about community transmission. How different is it from the regular transmission? Can you break it down really? What really constitutes community transmission of the coronavirus?
It's important for us to recognize that when looking at it from the roots, this is a pandemic. So pandemic is that it affects large parts of the world, not just one country. As we saw about Ebola, it's an epidemic because it's restricted to Guinea for now. But for coronavirus, it is all over the world. And because it does not happen like the normal malaria we see. Malaria is that a mosquito bites you and you get infected and you treat it. It's not contagious. It does not transmit by body contact. 10 people may be living in the same house and one person is suffering from malaria or typhoid. It does not mean that the rest will be exposed to it. But talking about the community transmission of COVID-19. It means that first, it's an infectious disease. It can pass from one person to the other through body contact, droplets, and when it gets a large number of people are infected, so the rapid state of it passing from one person to the other is high. So that is the state where we are now. And that's why we see numbers as opposed to 100. 1 year ago, we are seeing the numbers in tens. It progressed to hundreds. Now it's in thousands. Minimum average of 1,000 every weekday.
Almost every day.
So it means that in those locations or communities, this infection has affected a large number of people, and more persons are infected without knowing that they are contact with the other person, even though they are symptomatic, was the reason. Okay, let me put it in perspective again. The community transmission we see currently is driven by the fact that all over Nigeria, of course, virtually all the states, perhaps only Kogi that say they don't have it. So the number of people being infected is large, and the rapid state it can pass from one person to the other is very high. So now bringing it home again, a question you asked, if you check out, because this disease also mutates, so it's as if it has subsided or it has been eradicated. Places like New Zealand,
and then when you relax,
Australia, it came back. So we are having that situation with the second wave, because this second wave, like you pointed out, this second wave is more ferocious than the one we had before. It infects rapidly than the first one. So the implication is that we must deploy a collective action plan that would mitigate its continuous spread. And we are not yet there. Yes, there have been regulations the government has given. The federal government has issued a regulation. There are other protocols NCDC and Presidential Task Force has given out. But those things are not being adhered to. And so that's where the quagmire we have. And we don't have a cure. I talked about malaria. Malaria has a cure. I had malaria treatment last week, and I'm better. I'm strong on my feet. That does not apply for COVID-19. We don't have a cure. We don't also have the vaccine. And we have not also...
Especially in Nigeria.
So even in the rest of the world, over 130-something countries have not yet received a vaccine. They've not administered any in their soil. In Africa, even South Africa that got 1 million, have not yet started using it. So we've also seen comments and references to a new drug, Ivectimine.
Yes, exactly.
And
I was going to talk about that, really. The controversy around it, or the availability of it, you know, when it came out first that the drug has some level of potency, or if you have to put it that way, against COVID-19, and then the demand rose. You remember the days they were talking about hydrochloroquine, as the case may be, and they started disappearing from the shelves in pharmacies.
Interestingly, okay, there have been some research. Some Australians conducted the research, and it showed about 62 to 92% potency in terms of efficacy. But it has not been conducted here. Professor Remy Babalola is actually leading a team conducting a research. And I feel for Nigeria, necessity is the mother of invention. This is the best time, since we are not making rapid progress with getting the vaccines, and this can be used as a prophylaxis. I mean, this Ivectimine. So we should deploy resources fast, identify the efficacy for our local needs and the side effects. So if it has proven to have been used either for prevention or for cure, and it has worked, so it requires that can be a buffer to whatever challenge you are having
while we wait for the
vaccine, and when any other curative drug will emerge. So it is something we ought to have done like yesterday. I think NAFDAC and then the private sector. I still want to call on Kakovic. I want to call on leaders in the health sector to accelerate their action plans regarding this. That could at least serve, because it has proven to be very effective for parasitic treatment like river blindness and roundworm, as well as scabies. And even in the US, I also read that they've conducted research, but because also there is also this aspect of, some people call it vaccine nationalism. A lot of the big pharmaceutical firms have invested heavily to come up with a vaccine. So most of them are not easily promoting this, because the drug is less than 100 naira per tablet. I have seen pharmaceutical companies, pharmacy shops actually, that are displaying it, buy this here for COVID-19. Actually, that is a bit curious. So it is likely that because there are a lot of investments have gone into it from the Western world, they may not be very quick to push for its adoption. So for us, we can't be in a dilemma as a nation. What we must demonstrate our sovereignty. Okay, if this thing can serve our local needs in the short run, why not we exploit it?
Well, the point there is, when it comes to the capacity of Nigeria to begin to research, well, of course we know that trying to research into a vaccine can take so many years, 10, 15 years sometimes, 2, 3, 4, 5 years sometimes. But efforts have to be made from now. Now, let's get back to the basics. When we had the anxiety about COVID-19 last year, people were so scared, and it was easy to adhere to all the protocols that were, were advised by the ministry and by government. Stay home, ensure you have social distancing, wash your hands, use face masks, and all of that. But now that the constant, information out there have made people to feel, we know what this thing is about. The death rate is about 0, or at least less than 1 or 2 or 3%, and all of that. And now we see people not adhering to those protocols. What more can we do at this time, really? Because comparative to early last year, there's more information out there now.
So we have seen TVC and other television houses running documentaries, highlighting the number of people who have died, those who could not access oxygen, those who could not access care on time. And there was also a regulation the president signed in last 3 weeks or 4 weeks ago, and we thought that could be a deterrent, and it remains the
Although
same.
in Abuja, some
there were
arrests
just
were made.
pockets of arrests. That does not. So yesterday I got a call because our organization Health Emergency Initiative, because we support emergency response systems, complementing what the government do, as well as give out PPE to health workers. People checked online, and one called me that he's calling from K2, that in his area they were having party in breach of the protocol. So I said, call 767, someone will respond. But what that points to is that what we've done is not sufficient. It's not effective. We've not done so well yet. Because even as we speak, I lost 2 close persons last week of COVID-19. So what I'm pointing out is government must activate parts of what we use in curbing or curtailing polio. Health workers, sanitary health workers, complementing the law enforcement agents for sensitizing.
And health extension workers as well.
Health extension workers are better put. Secondly, we need to see a lot more engagement, sensitization and engagement, and resist disease risk communication. So if you go to, I have highlighted it on this platform several times, as long as the government has not done so much in engaging groups like NU, RTW, at unit level, at branch level, at divisional level, market associations, because those are the ones that can easily send the message that there is danger. And if you, this executive, this group, this branch, if ABCD happen in terms of breach, you will be suspended, you'll be removed, or this market will be closed down. As well as, I've seen that significantly most of the religious organizations are being more compliant. So if we push the message down, we will see a lot more compliance, because not many people listening or viewing, connect by this hour listening to us. Most people also do not have radio. Most people do not have a channel where communications get to them. But if he goes to this bus driver, engaging those people to be enforcers also, just empower them, but have certain regulations that you must handle this, you must handle this, and this is the way we monitor you. If ABC happens in breach, we'll come, we'll close you down, we'll remove you. You will see a lot more. And then, of course, when you mentioned Abuja, we go this extra length of pick those who have violated the law. Don't go about putting them in any detention facility or fine. Make sure they work their community. The punishment will be community service exactly. And it would require going to isolation centers to at least carry those oxygen cylinders for some days. They will go back.
They come face to face.
They connect with it.
Yes.
That is the best way to actually send the message home, and people will wake up from it.
When it comes to the way we live, we are communal people. Our lifestyles are communal. So when they say social distancing or physical distancing, it becomes really difficult for people to. In fact, till today, you still see people greet and try to shake or even try to hug and all of that. Do you think that's a challenge?
We cannot remove that from Africa. But I talked about disease risk communication.
Yes.
Someone, a pregnant lady, 38-year-old, who just finished her MBA from LBS last December. She died last week, Monday, exactly 1 week ago. And it was a heartbreaking moment. As much as we want to carry on with our communal life, and as I speak to you, I drive across some streets or corners, I see people gather in the evening, taking bottles of beer, no social distance, no nose masks, normal lifestyle. It's a tough one for us, but if we continue to dimension ways of communicating the risk inherent in all those things in a more effective way, it's not the usual way we've been communicating, because you must always check your communication strategy. Is it working? If it's not working, what could you do separately? Yes.
And then you re-strategize.
Yes, that is critical. So until we begin to relate it to our own realities, because the way you communicate to somebody in Lagos may not be the same way you communicate with somebody in Owo or in Bayelsa or in other parts. You find out what works for this community, what works for this group of people, what works for the corporate, what works for the everyday Nigerian, what works for the person that is hawking on the street. So, and design a communication strategy that will suit them. But we have just as I talked about New Zealand, we still have not come out of this. If we see, whether it's 500 or 1,000 something, again, it's very important to dimension that out of every 100 people that get infected, 10 or more will end up in ICU. And out of that 100 people, about 1.2 or 1.5 end up dying. So the more people with community transmission, the more people are getting infected, the number of deaths are going to increase. And nobody knows. He may be a billionaire. And it's not a big man disease, so it's important to clarify that. And Koro is not a scam. Koro is real.
It's real.
It has taken many people who know.
They named it Koro.
True.
And sometimes people just laugh over it, because Nigerians will try to find we get comical with a lot of these things as a way of easing tension, but the reality of it still remains.
And you see Ebola you cited a while ago.
Exactly, in Guinea. Yes. And that's going to compound the issues in the country right now.
Our borders are porous. The thing is that the concern here is, between February last year and now, one of the expectations of any right-thinking person is that health will be given a priority. The actions of stakeholders, government, private sector does not suggest or lend credence to that, because I know we also have other pandemics that are dealing with people. Insecurity, we have hunger, we have food insecurity and all of that. There is nothing suggesting. If you still go and check the private sector, over 70% of them still commit their CSR to entertainment-related programs, as opposed to this emergency we have. Health is wealth. Also, if you check the national budget, we only voted less than 6 to 7%, less than 7% to health.
To health.
So both federal, state, and other stakeholders, nobody is demonstrating seriousness that we have an emergency we need to fix. And primary health care, of course, whatever that happens, some of the cases, pre-existing conditions, they came to be because primary health care is in chaotic situation. We need to really, really roll our sleeves. Nobody is willing to roll their sleeves. Private sector, even social sector, NGOs, most people, you look, they limit what they do to advocacy. In health emergency initiative, we go in to make sure that results be part of it. Yeah. And the pain points of the people who identify it, we relate to the pain points. Okay. So we need to all work. The media also, let's give more attention to health, bringing it into focus. Good thing we are doing it this morning.
That is why every day we talk about this, to draw attention to the realities of it, and we'll keep doing it. Okay, Nigeria needs to do more with the outbreak of Ebola in Guinea, because all of this, Nigeria remains a destination for all of these. But we have to round it off here right now. Pascal Achudine, the CEO Health Emergency Initiative, thank you very much for what you do. And we commend you every time for the enlightenment. Besides the advocacy, you are there on the streets, you're there in the villages, reaching out to people. We really commend you.
It's my pleasure. Thank you for having me.
Thank you.
It's my pleasure.